Good afternoon, this is Board Member Doyle, calling back to the session, the Oregon Board of Pharmacy meeting, on February 9th, 2024 at 1:02 p.m. Had, left off discussing, package, Charlie, Charlie 9, and, had not come to a conclusion. During the break, staff had done some additional research for the board for contemplation, and I turn it over to staff member Efremov to explain that information.
Thank you, Board President Doyle. This is staff member Efremov. I just wanted to maybe clarify or provide some additional context or information related to part of the discussion on the consulting druglet outlets. So during lunch, staff huddled, and we thought that it would be good to share some of our processes that might help the board to understand. So when we receive an application, so when licensing and compliance receive an application, we assess that application to make sure that the functions provided are actually within that scope for that registration type. So we ensure that the people applying are applying for the right registration type. So with that, the application for the consulting drug list pharmacy lists a section where you would provide what are the functions. And it also has a section to list every Oregon licensed pharmacist and technician that is working at that location. So when we assess these, if someone provides an application that maybe meets a different standard, we would refer them over to remote processing potentially, or to the central fill, depending on what activities they're performing. So currently our consulting drug list pharmacies all have Oregon licensed pharmacists in their locations. So I know the board had discussed wanting to go back and potentially drawing the motion or whatever the correct language is. I know I'm not using the correct language, remotioning. But for the board's consideration, you most certainly can still move in that direction if you would like, and we'll still be on track from the previous direction from the board to bring back that division of rules for discussion at a future meeting. But I thought it was important for the board to know, to be informed that the consulting drug list outlets, the way that they are registered currently with the board today, have Oregon licensed pharmacists performing services to Oregon patients, even if they are located out of state. Thank you.
Member Doyle, staff member Efremov, for clarification, that is all 23.
Correct. Staff member Efremov, from the process that we initiated with the applications and how staff assesses them, the individuals performing consulting functions would be those clinical services that require licensure per the rules. Thus, we assess and require the the licenses verification for each Oregon licensed as part of the application.
Member Doyle, are there any other questions from board members for staff on this new information provided?
This board member DeVarmar. So going forward, remote processing out of state or a call center type for an Oregon drug outlet would still be licensed as a non-resident drug outlet, even if that location or facility doesn't have drugs. Oh, that is, it would be that's, as I'm understanding, that is how it currently is. It would just maintain status quo.
So remote processing is, oh, I'm sorry, staff member Hennigan. The remote processing is attached to a retail drug outlet.
Designation.
Yeah, it's a designation. It's not a license type. So where the consulting drug list is, and it's my understanding the functions are different.
Member Efremov, I think that apologize. Just to clarify, maybe the question from board member DeVarmar, are you clarifying that we will continue to, if a location is performing remote processing services but potentially does not have drugs on site, we could still register them as a remote processing location?
Would licensed as a retail drug outlet or even an institutional drug outlet, if they're maybe doing remote verification for IV mix, it would still be licensed as a drug outlet, even though they don't have drugs.
Staff member Efremov, the current construct is, yes, the relation to the duties that they're performing, if it is a remote function related to that retail function or institutional function, that's how we would register them. And point noted, and more additional conversation related to all of these. I appreciate you raising this so we can lump this into the bigger conversation with the consulting also.
Perfect, perfect. Yeah, just again, I don't want any unintended consequences down the road. Oops. So awesome. Thank you. And I'm glad that was a conversation we had. I feel much better. Doesn't sound like we have to unwind anything.
This board member Beeman, I believe we would potentially, I'm hearing the intent. Re-motion on the second part of this issue, the second vote that did not pass.
150. Board member Chin, you're referring to Division 115 that we would use a re-motion. But we don't need to undo. But we don't need to undo the other one that we already voted on.
Are there any further questions for staff? Board member Doyle, is there a motion to withdraw the previously made motion regarding mailing Charlie 7? And seeing none, we will move on. Is there a motion to move to adopt proposed rule OAR 855-115-0001 to be effective 3/1/2024? That's March 1st, 2024.
Member Clemens. So we voted on this already. Is there a motion to vote? Is there a motion?
Board member Doyle, I'm asking for a motion again. One can motion as many times as necessary, or for all intents and purposes. AAG Hunt, we're leaning into the mic.
I was just gonna say, the previous motion failed, so there's no motion on the table, right? And there's no need to withdraw it because it failed.
Board member Chin, I will make that motion.
For a second.
Member Beeman seconds.
Have a motion and a second to move to adopt proposed rule OAR 855-115-0001 to be effective on March 1st, 2024. Roll call vote. Board President Doyle, yes.
Member Chin, yes.
Member Beeman, yes.
Member DeBarmore, yes.
Member Hall, yes.
Member Hammond, yes.
Board member Joyce, yes.
Board member Patel, yes. Board member Vipperman, yes.
And unanimously passes. We now move on to package Charlie 10. Just staff member Melvin.
Okay, give me just a moment, please. Okay, again, this is mailing C10 related to Division 115 pharmacists. CDTM proposes to adopt permanent rule which relocates existing CDTM rules from OAR 855-019-0260 to Division 115. The Division 19 rule will be repealed to 2024. This rule needs to become effective March 1st, 2024. Back to you, President Doyle.
Uh, Now open for discussion from board members regarding package C10. Any questions or comments, please raise. In hearing none, is there a motion to move to adopt proposed rule OAR 855-115-0315 to be effective March 1st, 2024?
So moved, board member Farmer.
Second, board member Chin.
Motion has been moved and seconded. I now call a vote. Board President Doyle, yes.
Board member Chin, yes.
Board member Beeman, yes.
Member DeBarmer, yes.
Member Hall, yes. Member Hemmings, yes.
Board member Joyce, yes.
Member Pater, yes. Member Vipperman, yes.
Motion unanimously passes. I move to mailing Charlie 11, pharmacist prohibited practices with staff member Melvin.
Thank you, Staff Member Melvin. This is related to Division 115 Pharmacist Prohibited Practices. Proposes to amend OAR 855-115-0150 by removing diagnose from the list of prohibited practices. And this would be effective again, March 1st, 2024. Back to you, President Doyle.
Questions or comments? The
Member Hemmings. So. Diagnose is being in as a prohibited practice.
That is correct.
Pharmacists will be able to diagnose.
This is board member Chin. I don't think that's the implication. It's just not specifically drawn out as a. It's not.
Board Member Hemmings, is this the one where the statute doesn't mention anything about diagnose? So the discussion was about why, if you don't mention it, then it's just kind of like to individual discretion. And if we were to receive a complaint related to diagnose. And there's no rule that forbids it. It would be something that we would regulate.
Board Member Doyle, I may have an answer to your question. If we receive a complaint of an allegation of a violation, say a pharmacist diagnosing, agency staff would investigate this and bring forth all evidence to the board to assess and determine if there is a violation and law of law and rule, and if so, would it warrant discipline? The most likely violation in this circumstance would be OAR 855-006-0020 subpara J for practicing out of scope.
Remember Hemmings, but how could we say it's practicing out of scope if we don't have it, that you're not allowed to do it? Wouldn't it be, it wouldn't be a violation because we don't have anything that says it is practicing out of scope.
This is board member Farmer. We don't have anything that says we can't do surgery either, but that wouldn't be within our scope. We don't have to list everything. It's the point, that was the point of public comment as well.
Yeah, I agree with that, but I'm thinking down the road, right? In terms of what the implications of this would mean. Based on what President Doyle just said, that it would be considered practicing out of scope, but it's not because you don't have it as a rule. So it sounds very subjective to me. If we got a complaint, we're subjectively saying that it's out of scope, but yet it's not in our rule. And I know everything doesn't have to be in rule.
This is board member Chin. I'd just like to state that this is there's has been nothing in rule thus far about diagnose. It was implied in statute by being present, and so the argument was that it does not need to be in rule now because we've never had it in rule. My understanding that pharmacists are trained to understand what their scope is and that they can use their professional judgment. If they were to come before the board with a complaint, then we would address it like any other complaint.
Board member, I think where I'm confused is I thought that this was in rule and we're now removing it because it's crossed out.
Staff Member Melvin, please.
Staff Member Melvin, the board adopted this rule months ago, August, I believe, 2023. Because it's not effective until March 1st, we can't amend or do anything with it. So technically, it was adopted with the word diagnose. So on March 1st, what magically will happen at 12:01 a.m., diagnose will be in the rule, and then I will file, if this is how the board votes today, you'll see diagnose disappear. Does that make sense?
Okay, thank you. So board member Hemmings. So this board adopted this rule, which has diagnosis in it. But this board is now saying, I don't think that's right based on public comment. And we're going back now, we're gonna strike it so that it doesn't go into effect March 1st.
Board Member Doyle, one clarification. It's not this board thinks, it's what we all individually think, and we are making that decision now. So each of us will be rendering a vote as to whether or not that indeed this should be repealed or not.
What's the board? Member Hammond. The majority obviously voted for it. That's why it's here, right?
The majority voted for it during the rulemaking process, and now it's the final determination. Are we going to approve the repeal or not?
Right. And the majority, whatever the majority of the board says, it's the Vipperman who said the majority rules. Okay. So my other question then is, would you not need to go back? You're gonna revise this and remove diagnosis. Wouldn't you need to also remove it or change the verbiage that you have here where it says racial equity statement.
Staff member Melvin, I am not sure I'm following you. This, up in the gray box is where you're looking at. Is that correct? Okay.
So it's already been revised, it looks like. You're removing the prohibition of diagnosis in Oregon rule will no longer address the practice.
Yes, that is correct. So this, what
Why
you're,
do you even, sorry.
I'm sorry, go ahead.
This is what, why do you even need this if it hasn't even gone into effect? So it was never there in the first place, right? The ability to diagnose wasn't theirs in the first place because it hasn't gone into effect. So why would you even need to mention that you're removing it?
Staff member, because the board technically adopted the rule, even though it's not effective, it was adopted. So we have to undo what the board agreed to several months ago.
Member Doyle, staff member Melvin, correct me, or I'm asking you to confirm if you said that this rule for not being able to diagnose will go into effect at midnight, and then 10 seconds later, then
Yes.
it will then be repealed.
In theory, yes.
So we're taking the board is taking a proactive stance that this rule will in effect not go into action.
Member Henry, thank you.
There a motion to adopt proposed rule OAR 855115015 to be effective March 1st, 2024. So motion. Member Joyce. There a second?
Member Patel second.
We have a motion and a second. I will now call for roll. Board President Doyle opposed.
Member Chen abstain.
Beaman, yes. Member DeBarmore, yes. Member Hall, yes.
Member Hemmings, then
For Joyce, yes.
Member Patel, yes.
Board member Vipperman, no.
Motion passes with board members Beaman, DeBarmore, Hall, Joyce, and Patel in favor. Board members Doyle and Vipperman opposed, and board members Chin and Hemmings abstained. We'll now move on to package Charlie 12. Staff member Melvin.
Thank you. Mailing C12, this is Division 120, preceptor license renewal or reinstatement. This proposed rule adopts a new permanent rule that adds preceptor licensure renewal or reinstatement requirements. This is also to be effective March 1st, 2024. Back to you, Board President Doyle.
President, speak. 12. And hearing none, is there a motion to move to adopt proposed rule OAR 85512011035 to be effective March 1st, 2024?
So moved, board member DeBarmore.
For a second,
Board member Chen.
we have a motion and a second. We'll call roll now. Board President Doyle, yes.
Member Chen, yes.
Member Beaman, yes. Member DeBarmore, yes. Member Hall, yes.
member Hemmings,
Or Joyce, yes.
Member Patel, yes.
member Vipperman, yes.
Member Hemmings, can you please repeat your vote? I did not hear it.
Abstain.
Thank you. Motion passes with board member Hemmings abstaining. We'll now move to rulemaking policy discussion, etiquette rules in development, rulemaking policy discussion with staff member Davis. Before we get started, a couple of comments regarding etiquette. Again, reminded to please, for any board or staff member, to identify yourself as such with your last name, speaking one at a time and directly into the microphone. It's critical for reporting it as public record. For each policy discussion, staff member Davis will facilitate a roll call to poll the board members for their input. Once called on, it is your turn to speak and provide your opinion or comment on the policy being discussed. Comments will be limited to 3 minutes per board member. If you do not have anything to add to the discussion, it's okay to pass when called upon. Should a planned policy discussion organically arise on a different topic, for the staff will keep the current roll call and begin a new one on the new topic. Staff member Davis.
Okay. We are going to be opening mailing D as in dog. So today the board will continue its first review of the proposed rules for compounding in the new Division 183. As a reminder, this is part of the board's strategic plan to work systematically to refresh rules and standardize rule development. The strategic plan includes a key action of amending rules for drug compounding to ensure consistency with the updated USP chapters 795 and 797. At the August board meeting, I provided a presentation to the board on compounding, and then the board discussed proposed amendments that were needed in Division 6 for definitions, Division 41 for outlet general requirements, Division 43 correctional facilities, dispensing practitioner drug outlets, and community health clinics that would align the definitions and the outlet types with the amended compounding rules. As a reminder, I know that presentation was 6 months ago at this point. So it is in your board meetings folder in the August folder, but the presentation covered topics such as the New England Compounding Center tragedy, the Drug Quality and Security Act, specifically the Compounding Quality Act that's contained in the DSQA, available compounding technologies, FDA inspections of compounding pharmacies in Oregon, and board cases related to compounding based on inspections. At the December 2023 board meeting, the board discussed proposed amendments in this Division 183 related to personnel, and we began discussion on compounding general requirements. Today, we're going to pick up where the board left off in December of 2023. As a reminder, these rules apply to the preparation and dispensing of compounded drugs from a drug outlet. These rules do not apply to the preparation and direct administration of compounded drugs by a healthcare provider. The board utilized a work group to develop these rules. The work group met 5 times in 2023, in February, April, May, June, and July. And you can see those minutes on the board meetings webpage under the 2023. Search for the word compounding, they'll pop right up. It's been a year since this work group began meeting, so I want to kind of remind you of who the work group members were since it's been a while. The group included pharmacists, pharmacy technicians. We had a public member that was a naturopathic physician and 2 of our board members. All members had significant experience in pharmacy, specifically compounding, ranging from 5 to 40 years, with several exceeding 10 years. And all the members had that direct experience in compounding, including both sterile and non-sterile preparations, adherence to the USP standards, and their expertise spanned retail, inpatient, and manufacturing settings. One member also had expertise in veterinary compounding. The rule language that is highlighted in yellow denotes staff proposed amendments that were made between the rule package when it was proposed at the June 2023 board meeting. The board did not have a conversation or review these rules. We are still in the first conversation a year later, but they did send the rules to rulemaking for comment only. And at the August 2023 board meetings. The yellow denote changes that were made by staff after talking with the work group in the summer of 2023. Some language changes. So what you'll be hearing today are different than what was originally in the June packet, and those new changes are highlighted in yellow. After the board's review of this package is completed, board staff or agency staff will revise the rules according to the board's direction and bring further revisions to a future board meeting. So this is not a fast process. We will not be sending these to rule making right now. We need to get your feedback. We'll work on the rules and come back with revisions. Now I'm going to skip ahead to where we left off, which is OAR 855-183-0200. And can you do a control F? You have to scroll. I don't know what the line number is. Oh, 200.
Okay. I remember Doyle had one clarifying question with regards to the yellow highlights on this package D. In some places, there is a yellow highlight of the first letter of a word and then the last letter or a punctuation mark of the last word or of the same word. But the whole word itself is not highlighted.
Just so that it wasn't bright and overwhelming. It's just that word changed.
Okay.
Yeah. I
So
just tried not to like make it a big yellow highlight, the whole document.
One would say that the two yellows are the bracket of the information that has been revised.
Correct. Staff member Davis, those are bookends of the language in between the start and stop that's been revised. And I'll talk about what that revision is as I go through. So we started talking about 855-183-0200. And this is where we would adopt the new standards by reference. So the new USP 795, the new USP 797. One discussion that we need to have that has been added new to this package because it keeps coming up and we had not discussed it previously, but it fits with this rule where we were at. We're going to start out by talking about flavoring of compound or of medication. So flavoring medication helps the patient to take the medication. Flavoring is typically added to liquid children's medicines is probably the most common use. And then also medicines for animals. They're flavored like tuna to make it taste better. Since the board adopted OAR 855-045-0200, which is the rule that this revision is based on, they adopted the last revision in 2019. Adding components such as flavors not stipulated in the manufacturer labeling of a conventionally manufactured product has been considered compounding as defined in USP 795. As you all know, USP published a revised standard in November 2022, which is why we're looking at these rules to update them and adopt the newer standard. Those rules or those standards became official on 11/1/2023. In Oregon, currently, our pharmacies can choose to use the old standard or the new standard. We have a rule that the board promulgated and has adopted. So some pharmacies may be complying with the old USP 795, some may be complying with the new 795. The revised standard defines non-sterile compounding as combining, admixing, diluting, pooling, or reconstituting other than as provided in the manufacturer's labeling or otherwise altering a drug product or bulk drug substance to create a non-sterile preparation. Adding components such as flavors not stipulated in the manufacturer's labelings is compounding as defined in and has been within the scope of the USP 795 chapter since it was first published in 2004. Flavors are organic chemicals with reactive functional groups, including acids, alcohols, aldehydes, amides, amines, esters, ketones, and lactams. The effect of adding these substances, even in small quantities or concentrations, to conventionally manufactured products is unpredictable due to the potential for a variety of chemical reactions. And this is a statement from USP. And this is what I'm reading. Following the requirements in USP 795, when compounding, including when adding flavor to conventionally manufactured non-sterile products, helps to minimize harm to patients that could result from 1, excessive microbial contamination, 2, variability from the intended strength of the correct ingredients, 3, physical and chemical incompatibilities, 4, chemical and physical contaminants, and or 5, use of ingredients of substandard quality. But To follow the 2022 version of USP 795, a pharmacy must adhere to many standards, including, but not limited to, having a designated person who is responsible and accountable to the pharmacy for the compounding operation and personnel. Personnel must be trained and demonstrate proficiency in a number of core competencies like hand hygiene, cleaning, calculations. Personnel must remove outer garments, jewelry, or piercings that would interfere with any garb or hand hygiene. They must wash their hands for 30 seconds. The pharmacy must have a designated area for compounding, hot and cold water and accessible sink, temperature monitoring, along with quality assurance and quality control programs, recall procedures. Master formulation records and compounding records must be created and maintained, and labeling must indicate the medication was compounded. Supporters of flavoring being exempted from compounding standards argue that because the flavoring volume is less than 5% of the total volume of the drug, that it is not compounding. USP, however, maintains that even with less than 5% of the total volume, flavoring a manufactured product is compounding and must be conducted under compounding standards. While agency staff have not confirmed this data, supporters of flavoring being exempted from compounding have shared information that 49 of 52 boards of pharmacy have determined that USP 795 for non-sterile compounding standards does not apply to the practice of medicine flavoring. Further, it states that regulate flavoring with full adherence to USP 795 are our neighbors to the north in Washington and our neighbors to the south in California. There are four states that have not taken a formal position, including us, on the new standards for 795 and whether this flavoring is compounding. So today you get that opportunity to take a position and give an indication as to where you want to head. Agency staff are requesting board direction if you would like to see flavoring to continue to be considered compounding in Oregon, or if you would like for staff to draft an exemption to adherence with the standards in USP 795 as it relates to flavoring. Back to you, Board President Doyle.
President Doyle speaking. I believe that there's some current legislation that we're tracking. Can you comment on that and how might incorporate that into and how that we might want to limit our discussion today on that?
Try and find the bill number. Hold on just a second.
4010.
4010. I put in 1410, so thank you. It's like, I know this number. Yes, there is a bill in the legislature. It is currently in the House Committee on Behavioral Health and Healthcare. It's had a public hearing and it has a scheduled work session on the 12th, which I think is Monday. It does have some language that would, in effect, specify that flavoring of a prescription drug is not compounding. Whether the bill makes it through or not, you never know. It's the legislative session. If the board were to vote that flavoring should be exempted from compounding, we would likely look at that language as potential language to create a rule. They've already written it for us. It might need a little bit of edits, but it's a pretty good basis. It is pretty similar to language that some other states have used. So is that what you were looking for?
Yes, excellent. Thank you very much. I will begin our round robin where we had left off in our cycle yesterday. That means the board member DeBarmore has the opportunity to speak first.
This is board member DeBarmore in actually it took one way and I spent quite a bit of time on this one. I had the privilege, I guess, of attending a session that was the group of folks that participants in revising the USP chapter. So the experts, there was a one program that we attended. It was sponsored by NABP. It was an excellent meeting, and they spent several minutes discussing flavorings and put a lot of consideration into this topic, and it wasn't something that was like we brushed by. And those are the experts. They were chosen for a reason. I feel like there's a reason, so it was important that we went to that. Continue to follow that flavorings would be compound.
Member Patel?
I would say we should exempt flavoring. Turning as a compounding. I would like to stick to the FDA definition. And then most of the board members I talked during the NABB meeting, they also say they start the state they exempt. They would go.
Staff member Nolan, do you need, board member?
I'm just having a hard time hearing. Board Member DeBarmore and Patel, do you guys put your microphones a little bit closer? Thank you.
I'll talk
Board
that.
member DeBarmore has advocated, for it to be considered compounding. Board member Patel has indicated that it would be carved out from compounding.
Yep.
Board member Hemmons,
Nothing to add.
Member Beeman,
Member Beeman, I do not think we should create any rules that are outside or different than the current USP standards. I think that it creates a area that may be gray or confusing for licensees unless affect patient safety via the confusion. In respect to flavoring specifically, I am not in favor of carving out an exception. I trust the experts that have revised and reviewed and thus published USP that they have done their due diligence on this and mirror a lot of the sentiments of what we heard for Divine regarding that topic.
board member Hall.
Member Hall. In my concern is with patient, compliance. They're, patient doesn't taste good, they're not gonna want to take it. So if there's not any information out there that we could put a flavoring in it, X drug, and is that something we need to consider? Like it might hinder patient care, so I'm not at this point in favor of including flavoring as compounding.
Member Vipperman.
Board member Vipperman. So when I read up on this, read up on this, and then it occurred to me that in our strategic planning, we had talked about not differentiating from the federal rules. And this is the standard federal rules.
This is an independent standard. We would be adopting the standard as our rules, but it is not a federal rule. It is just an independent standard that many boards adopt.
Thought it was, I thought this was, because I'm not up on that. I don't want to be up on that. But my thought process was, oh, okay, well, I would like the exemption because I have been in a pharmacy and I know that is used, and it could create some accessibility for the patients who actually need the flavoring to get that flavoring. That's where the exception would come in handy. Is it a patient safety? So that's my number one priority is patient safety. So I would agree to the exemption, but I didn't hear enough of board member DeMar Moore's explanation of why they thought that it was important to leave it in there. They thought it was important to leave it in there as compounding as opposed to having the exemption. So that's my thoughts.
Member Doyle, we'll come back around to Board Member Beeman after everybody's had a chance to speak. Board Member Doyle, my personal recommendation is that at this time, I would say that's not considered, flavoring is not considered compounding, but there would be special circumstances that I would like to, or restrictions that I would like to place around it. But I'm holding off with those particular recommendations, considering the bill that's being currently contemplated in Salem. Remember, Chin?
I just see two sides of the coin with the testimony we had from the pharmacies who are compounding, particularly for children, and not being able to make medication accessible, i.e. safety that they'll take, being a big issue. But then I also understand Member DeBarber, and then the introductory talk from board staff about how flavoring actually has chemical compounds that do alter chemical compound or can alter the chemical compound of particular drug product. And so there are patient safety issues on both sides. And so I'm sure what to say.
Board Member Joyce?
Board Member Joyce, I support the exemption of flavoring. The feedback from the stakeholders has been that, yes, it's a small percentage of the total volume. And although there's a potential there, the microbial contamination and so forth, we're talking about a non-sterile product, and flavor does make a difference. For example, in our hospital, in the pediatrics section, we had to change Tylenol, liquid Tylenol into a different flavor because the children there just were just hated it. And the nurses were having a hard time administering Tylenol to the peds patients there. So we changed it to change the flavor. And this is slightly different. We're talking about adding flavor, but flavor doesn't make a difference. If we're talking about patient safety issue, if we were able to give the peds patients Tylenol because it tasted better or it did not taste terrible, then that's a thing for patient safety, right? So I do support an exemption for flavor.
Member Beeman?
Thank you, Board Member Freeman. I would just like to have some clarification for transparency around a comment made by Staff Member Davis and comments previously made that these USP documents are guidance or guidelines. These USP documents are enforceable by the FDA. And it has been made very clear to us as a board previously, and it was a few years ago, to me as an individual at many conferences and on many CEs, that these are not guidelines. They may be listed as guidelines or guidance, but it is not in the sense that we use in the term commonly within this realm of discussion. These are, according to the FDA, the standards that pharmacies need to follow. And I just want to make it clear that it's not a guidance that should be taken lightly to not consider. It's been made very, very clear. The FDA will hold compounding, any compounding, anywhere to the standards of USP.
Any other comments? Seeing none, I would recap that board members DeBarmore and Beeman recommend that flavoring is compounding. Board members Joyce, Patel, Hall, Zimmerman, and Doyle have indicated that it is not. Albeit there may be certain stipulations or restrictions that would put place around it. And board member Chin and Hemmons did not voice a strong yes or no.
This, for the interruption before we wrap this up, this board member Chin, I would like to ask a question about what trumps what. If the FDA, USP, your regulations, not guidance, but regulations by the FDA say that that this needs to be followed. And the state does legislation saying that, yeah, no, you don't. Because we're gonna write into a rule that flavoring doesn't count in your FDA thing. So how does that work how does that work? I don't understand that the FDA says that this is this, and the state says, well, we're not gonna pay attention to the FDA, we're gonna say it's this. So how does that work in terms of us writing a rule or not, or carving out something that the FDA says is this?
Board member Doyle, marijuana comes to mind as an example, but staff member Efferbaum.
Staff member Effermoff, I think one point of clarification. So the FDA actually regulates to good manufacturing practices. So pharmacies are exempt from following good manufacturing practices if they fall under 503A. That's the exemption clause. So if pharmacies are under 503A, the FDA does not necessarily have jurisdiction over you. So that's when the standards come into play related to USP. So pharmacies 503A, the board is adopting those standards by reference to be able to enforce those. The FDA will enforce good manufacturing practices, and they also have authority over outsourcing facilities that have a slightly very good manufacturing practices requirement. So there's a little more subtlety in who has jurisdiction over what. But I would hand it over to our AG related to federal versus state, which is a different legal perspective potentially on jurisdiction.
I mean, I've never heard of USP before today, so I'm not sure if I can speak to it in any way, shape, or form. But just, I mean, federal typically trumps, but if there's an exemption. Legal advice on if you want it, I can't speak to it today.
Member Beeman, is it not correct that the FDA can go in and inspect and thus report to the boards and then the boards discipline on those inspections?
Staff member Effermoff, my understanding is the FDA would initiate based on issues that would potentially not allow, that would fall outside of that exemption. So if a pharmacy is operating like a manufacturer or outside of what 503 very narrowly exempts, then the FDA does have a jurisdiction to go in. So yes, state and federal government agencies communicate, but I'm not quite sure if that answers or addresses your question.
Sorry.
I might go.
My understanding, and that's what we talk in the NABP board member forum, and I'm going to read words to word, that reliance on state licensing board. The final guidance explains that FDA will rely on compounding pharmacies, home state licensing boards to provide day-to-day oversight of routine compounding practices, but that FDA may provide concurrent oversight of compounding practices when considered appropriate. Should FDA have cause for concern, the agency indicated it may also refer the matter to appropriate state licensing board. To me, if FDA, whether you are manufacturing, whether you're 503B or whatever, if the FDA want to inspect my compounding pharmacy, yeah, they will. If they have concern, they can also tell Board of Pharmacy that you have to inspect and you can take disciplinary action. So to me, ultimately is the FDA the regulatory body. That's what I got. And then with the USP is not the regulatory body, but USP is not a regulatory body and does not enforce the standards. The FDA and joint commissions are regulatory bodies and can enforce the standard. That was discussion, that was I understand, and I verified. It's also in the NABP innovation medicines as well. So
Member Davis, can you take us to the next section, please?
Move to the next discussion within this rule. And just to kind of recap, at the last board meeting, we ended with having, to find my notes, stopped here. Okay. We had talked a little bit about utilizing different types of verification of compounded non-sterile products and sterile products, either using systems that incorporate barcoding, verify the ingredient quantity using gravimetrics or imaging. And we had a very kind of cursory preliminary discussion and received some general board direction as to what we should, work on the rules. It was very brief. I remember it was just like a 5-minute discussion. So I wanted to kind of revisit that just to give, because you've had a little bit more, we have a little bit more time to discuss today. The proposed language, and this is why you had a 4-1-1 and a 1-2 and a 1-3 was very like, let's just get a read on the temperature, let's say, of the board and where we want to head. So in 4-1-1, it talks about using verification of both sterile and non-sterile preparations to have barcoding, and utilizing barcoding. The work group discussed this at length and had suggested if the board were to enact a rule to put about a 3-year effective date, given I was working on this a while ago, so that date would need to change. And they cited a benefit of adding in language now that something that would be in effect in like 3 years would allow outlets to know that something is required by rule. They could procure the resources and the funding so that they could implement it. And there have been some board conversation and comments around that. We also discussed about verification of compounded sterile preparations using imaging or gravimetrics. And the work group agreed that was the right direction to head, but they weren't comfortable with having a must for imaging and gravimetrics. Again, if it were to become a must, even with a future implementation date, it would need to be 3 to 5 years in order to get the budget and the resources in order to do this. In 4-2, this was a different option. It was a permissive statement. So just saying you may use a system that incorporates barcoding and imaging for CNSPs and CSPs. And then 4-3 was again a permissive statement, but only related to sterile compounding. And permissive statements are not necessarily rules that can be enforced, but they're kind of like giving a nod towards direction of the board, or that the board thinks that a pharmacy should implement these sorts of technologies. And so we went around and had just kind of a very preliminary discussion. And I don't have my notes particular to that conversation, but I did want to just give an opportunity to come back now that you've had more time to think about it. I think the big key pieces are, do you want any or all of this, right? Like, do we want barcoding for CNSPs and CSPs? If so, how long of a lead-in time do you want? Do you want imaging or gravimetrics, which is mostly related to, it could be more likely CSPs, but imaging and gravimetrics for both, or one or the other? And do you want a lead-in time? So just kind of looking at the options, and these are really technology options to help ensure safe compounding. barcoding, we know, and I presented data on this back in August. If you look at that presentation, barcoding definitely decreases errors, right? And making sure that you have the right product pulled, that we don't administer a completely wrong product or put it in the bag when we're mixing. Imaging and gravimetrics, again, it's another way of second checking it's the right product. The gravimetrics is really fancy technology, right? To make sure that the right volume was inserted and then the bag weighs what it should at the end, or the right amount was put in a tablet or a capsule and the right weight is there at the end. So these are just tools to help ensure safe compounding. And so I'm going to give it back to you, President Doyle, just to get board feedback. Just again, now that we've had a little bit more and you're not rushed to have a conversation about barcoding, imaging, gravimetrics, sterile, non-sterile, yes, no, lead in time, just so I can bring you back a new set of rules.
Member Doyle, thank you. We begin with conversation and recommendations from Board Member Patel.
Board Member Patel. So for barcoding, must absolutely not. It should be may utilize the system. We are talking all the three at the same time or one by one, barcoding and imaging together.
All together.
So no, in my mind, there shouldn't be a must in any rules. And no, that you always have to consider, sure, if we are talking about the big hospital, like, Boston Children's Hospital or OHS, sure, do the barcoding, sure, do the imagine. But no, there's a two patient room hospital in rural area. No, they have to shut down that hospital. So there shouldn't be a must for barcoding. There shouldn't be, they may use the imaging if they have money that hospital, but the may is fine. And I don't think so we should put any date or anything. For me, should be May. All three.
Member Hibbins,
And to add,
Member Beeman,
Member Beeman, if we are going to implement rules or put rules into our rules that are of this nature at all, it should be may. USP does not mandate a must. It should not differ from USP. And though it seems I'm on two sides of the fence as to even including it at all, if we did include it, may would indicate and provide a avenue and highlight a potential improvement that a pharmacy could make as they're evaluating their quality systems. Thank you.
Member Hall.
Member Hall. I agree with using may. It's definitely safer for patients using barcoding, but I'm concerned about the cost for these smaller facilities. With all this technology, I would hope that we could also consider allowing a pharmacist to verify remotely. I know that's not part of this.
Board Member Vibberman agrees with the may. I don't think must should be in any of these. And actually, I just reiterate that I am not the expert in this, but I just wonder why we needed those there in the first place. I was with Board Member and then I understand about this patient safety of the bar scanning. We use that in our hospitals now, but I don't know if it needs to be the question of must or may, definitely not must.
Board Member Doyle, I'm understanding that we have our experts in the work group, and I believe I understood that Member Davis to identify that 411, written as a must was a recommendation of the work group. And that others, their recommendation was may. I agree with the input from the experts from, our work group. And if we're talking about an implementation date secondary to must, I would agree that a 3-year implementation date, seems to me as if it would be sufficient time to gather the technology and, write SOPs, et cetera, and make that effective. Member Chin?
I am comfortable with the May, given the conversation. And then is all this information in the USP? It's not in the USP.
No.
So we do need to have it in rule then?
That's our decision.
Would, that will defer to the experts on this and if it needs to be in rule, but I would go with May.
The experts being
In our room.
our room as opposed to,
Licensees in our room.
as opposed to the work group.
Well, 2 of the board members were on the work group.
Two of the board members were present for the work group, yes.
Still defer to the
Remember Joyce?
Board Member Joyce. So, barcoding, very important for patient safety. It ensures you have the right product. When you scan it, it's the correct product. Or it's not the correct product that you use in patient safety. In regards to CNSPs, barcoding, for me, because we're talking about non-sterile products, and these are, medications that are mixed in usually outpatient settings or even in an inpatient setting, it's a non-sterile product. I don't think we need to implement barcoding necessarily. However, for CNSPs, however, if it's the recommendation of the work group for CNSP, then I will support that, and I support a 3-year implementation plan. CSPs, most definitely barcoding. We use it now. We've been using it for years at Providence Hospital. I understand that it may affect some of the smaller hospitals. I think that if we give them a 3-year head start on this, that they can get something implemented in regards to the very least barcode scanning. At our hospital, we're already using image capture. We're using it for high alert products such as insulin products that we admix in sterile goods. We're using image capture for that. We're using image capture for opioids, for anticoagulants like enoxaparin and heparin that we're mixing in IV flow goods, and chemotherapy medications. There are certain medications that you have to use image capture. You don't want the technician mixing it before a pharmacist can see it. The pharmacist should see it before the technician that mixes it. Gravimetrics, I mean, it's only really used for TPNs and products like that. I lean more towards the must because it's a recommendation of the work group, and also because of and also especially for high alert, high risk medications. I don't necessarily mean a must for every single medication, but definitely for the ones that we really need to keep a close eye on. That's where I'm at. And again, 3-year implementation plan.
Member DeBarros?
board member DeBarmore.
Don't have in our rules that pharmacy has to scan the barcode filling a prescription. Becomes standard of practice. It's safety. Just how it's become, because it's for patient safety. We didn't have to mandate that. We have to put in our rules. The right thing to do. Implemented it as they could. Quickly as they could, because it was the right thing to do. Just risk for their organization. And it's this similar in similar practice. I would hope that any organizations have already implemented, because it is the right thing to do. It is best for patient safety, for barcode scanning, same as DC scanning when you're filling the prescriptions. Would prefer not to have words in the rules beyond what is USP. USP is comprehensive. And, but if it is the will of the consensus, I would say may.
Any additional comments? Member Patel.
Member Patel, yeah, I was a part of the work group, and just for the clarification, this stuff is not in the USP, but the way it was presented in the work group, like you have to choose, it's like you have choice, but actually you have to choose one of those options, may, must, something like that, but there was no, I don't recall that work group members said like, please include all those rules, in that compounding package. I don't recall that. It's like, so for me, I don't think so we should include this, all the three, into our rule package.
Your comment? Staff Member Davis.
All right, we'll move to the next discussion. It's in parent 5. This is another one I expect robust discussion on. All right, so parent 5 reads, it is recommended that verification of CNSPs and CSPs not rely solely on the verification of components after they have been added to the final container. This includes methods such as proxy verification and the syringe pullback method. This rule was originally included in the prohibited practices section of these rules, so compounding prohibited practices. However, the work group provided direction that eliminating this practice would need a long implementation deadline timeline, such as like 5 years, and that it's the right thing to do for patient safety, but at this time it should be a recommendation and rule that signals the direction of the board without making it a requirement. In 2016, the ISMP, which is the Institute for Safe Medicine Practices, their sterile compounding guidelines included a statement that says proxy methods of verification of ingredients, such as the syringe pullback method of verification, are never used. In the 2022-2023 ISMP targeted medication safety best practices for hospitals, best practice 11 states that when compounding sterile preparations, perform an independent verification to ensure that the proper ingredients, medications, and diluents are added, including confirmation of the proper amount or volume of each ingredient prior to its addition to the final container. Specifically, they state that you should eliminate the use of proxy methods for verification for compounded sterile preparations, checking a label instead of the actual ingredients, except in emergency, perform verification in all locations where compounded sterile preparations are made, including patient care units, and use technology to assist in the verification process, such as barcoding of ingredients, gravimetrics, imaging, to augment manual processes. When the technology is in use, it's important that processes are in place to ensure it's maintained, the software is updated, and the technology is always used in a manner that maximizes patient safety. Does the board agree with the work group that you would want to put in this language in parent 5, possibly with a beginning July 1, 2029, sort of a really long date to help eliminate this practice use in our pharmacies? Or do you want to change this? Do you want it as a may? Do you want it as a must? Do you not want it at all? This is back to you from President Doyle for discussion.
President Doyle, thank you. We begin answering your question, starting with Board Member Hemmons,
Nothing to add.
Member Beeman,
Member Veman, I don't like this practice and I've never seen it. My career, and when I first found out about it a long time ago, I was appalled. If we put these rules into our rules at all, a statement names is keeping it as recommended, i.e. the may option is what I would be in favor of. Again, just don't want to differ from the USB guide.
Member Paul,
Right now, I would say may. But for patients, they don't like the proxy verification method, the pullback method is unsafe. I feel like if we said must here, then we're kind of going back. The other section. You're gonna have to have some imaging or something in order to verify, right? So, go with me.
Member Bivens,
Board Member Vimmerman, I just want to make sure I understand here. The pullback is when you pull it back and then the pharmacist looks at it
After you compound it.
after it's already compounded. So the current practice is you pull it back, the pharmacist comes and looks at it, and then you do your thing, right?
So
Current practice.
Well-
that is that's ideal. That's what the board is saying thus far, is that is the ideal methodology to do it.
We,
Okay.
I mean, that's what we, so I want to make sure, okay, so this is saying that they want to make sure that it's not pulled back, it's done after, it's not done after, right? This is saying, okay, that can't be done. I just want to make sure I'm correct in mind. So I think that's 100%. We should have that in
As a recommendation
as
or
a
a requirement.
recommendation. I think as may or must.
That's the question.
I think that is a must.
Board Member Doyle, my opinion is that it should be in our rules. It should be a must. There are many other opportunities to use safer practices that are not time intensive, et cetera. Or Reverend Chin, Member Joyce.
Board Member Joyce. So, I've worked in a variety of settings where, one method was for us to write the volume on the label of how much fluid we injected into the bag, and then showed the pharmacist the vial and a pulled back syringe. Like, President Doyle has checked a few of my IVs in the past, and we've used pullback method. It is unsafe. I strongly recommend the must in this. However, I don't think we can do it for every single product that we add mix, because there are some stat situations that can where you can safely add mix a drug and use the pullback method in some instances. So I don't support a universal for all medications, but I definitely support the majority of medications, and definitely the high risk medications. The pullback method should not be used. So I do agree with a 5-year implementation plan, because this will take time to set up a protocol and use image capture and all that to make sure we're looking at patient safety. There have been mistakes made with the pullback method, and you really have to trust your technician to make sure they're honest with that, the volume that they put into that bag with using the pullback method. So this would be eliminated with using, but by not using the pullback method. So, thank you.
Member DeBarmore.
Board member DeBarmore, I would be fine with leaving it as it is written as recommended.
Member Patel,
Member Patel. It's unnecessary in the rules, but if I have a choice, then leave as it is, and it shouldn't be used must in our rules, so I'm fine as recommended.
Board Member Doyle, looks as if we have three mays, two musts, one maybe a must. One not wanting into the rules, but conceding with may, and a couple of no comments. So it seems to me as if it's leaning towards a general may overall, so. Is that satisfactory for you at this time?
Yeah, the language as proposed in line 607, it is recommended, so it's essentially a may, and in the language, like, is recommended you not use this.
Thank you. It's, for, 223, Executive Director Fox, is it okay if we take a 10-minute break instead of 15? So I need to call for a breakdown to confirm with staff how to organize the rest of the schedule. And we'll meet back in 10 minutes at 2:34. Thank you.